the paper is going to be Indra, who's the IRJ's co-founder, and fielding questions in the comments box if you leave them there. Rosemary Ho and Jim Zong will be picking them up. Rosemary Ho is an IRJ's member, and Jim Zong is the president of the BSIRT. So without further ado, we're just going to crack on. I'm going to, based on some feedback we've had from previous sessions, I'm just going to give you, for the medical students out there, just a brief background into genicular artery embolization, so you have some basis to, relate to the conversations a bit later on. So I'll share my screen now. Okay. And put that there. Okay, so genicular artery embolization. This is a proposed treatment for osteoarthritis of the knee. This is a very common condition and can be extremely debilitating. Risk factors for it include increased age, so those over 45 are more likely to get it, obesity, younger patients with previous joint injury such as anterior cruciate ligament injury or meniscal tears are also at risk. And there is an association with ethnicity. If you're Black or Chinese, there's an increased association as well there. The cause of osteoarthritis of the knee is usually thought to be a mechanical thing, just to increase wear and tear, but more research has shown that there's a complex interplay of metabolic, biomechanical and biochemical factors at play. So the severity of osteoarthritis is graded on this very old system at looking at radiographs, knee x-rays, and the severity ranges from 0 to 4, 4 being extremely severe, 0 being no disease. And you climb up the scale if you have reducing joint space or osteophyte formation, so more or larger osteophytes being formed. Sclerosis, which is density of the bone, which is irregular at the articular surface, and then also deformity of the articular surface, so flattening or even further deformity makes it more severe, so any of those. It commonly affects the medial tibiofemoral compartment or the anterior compartment, which is known as the patellofemoral compartment. The areas that the grades that GAE is looking at treating is grade 1 to 3, and if you have grade 4, it's basically just a surgical option that you have available to you, so total knee replacements. So what treatments are there for grade 1 to 3? Well, conservative measures include weight loss, physiotherapy, and education. These have varying degrees of efficacy. Medical management is really tailored towards pain management, so paracetamol, NSAIDs, or opioids. And there is some studies looking at antidepressants, whether that lifts your mood and gets you exercising more, but the jury's out on that one. Intra-articular therapies include corticosteroids injections. That's by far the most popular intra-articular therapy, and that's shown to reduce pain for about 2 weeks, and then it comes back. The problem with corticosteroids is the long-term effects of corticosteroids include damage to the cartilage and osteonecrosis, among others. Hyaluronic acid injection is basically a lubricant, and I think the evidence for that is not very strong. Platelet-rich plasma injection is an interesting one, where you take your patient's blood, spin it down, separate out the red blood cells, concentrate the platelets and the plasma, and that's re-injected into the patient's joint, and that's supposed to encourage a myriad of healing factors, which I don't fully understand, and I don't think the evidence is very strong for either. Then some more experimental things include stem cells, so introducing stem cells into the joint space, and that's supposed to stimulate, well, if they differentiate into chondrocytes, that's supposed to regenerate the cartilage or have other improving factors. And the injection of autologous microfragmented adipose tissue is basically where you take the patient's fat away and you turn it into microfragments, re-inject it, and that's supposed to have some sort of benefits as well, but that is still very experimental, I think. So the surgical options for grade 1 to 3 include arthroscopic lavage and debridement. So it's a minimally invasive surgery where ports, so it's a keyhole surgery for the knee, ports are introduced into the knee and you wash out the knee with liters and liters of fluid, and then any irregularities of the articular surface or the meniscus can be taken away, smoothed out, and any loose bodies can also be removed. I think a randomized control trial New England Journal of Medicine suggested that the outcomes weren't quite favorable for that either. So what are we trying to treat? So earlier I described that there was a complex interplay of factors, biomechanical and biochemical, which contribute to osteoarthritis. So one avenue that GAE is trying to address is, if you take a normal joint here, you have this articular surface, which is avascular. Beneath it, you have the chondral junction, osteochondral junction, which supplies nutrients to the articular cartilage, as well as the synovium. And the synovium secretes synovial fluid, which again nourishes the cartilage, which doesn't have a blood supply. Now, in osteoarthritis, it's proposed that you get fibrosis and inflammation of the synovium. That in turn recruits macrophages, and macrophages secrete these or release these pro-angiogenic factors. And there are many of them, but the most popular or the most reported one is the vascular endothelial growth factor, or VEGF. And that promotes the growth of these new abnormal blood vessels into the joint space and across these new channels that form through the cartilage. And with them come sensory nerve fibers, and that's believed to cause pain. So how do you do the procedure? Well, this is the anatomy that you have to get yourself familiar with. It's usually an antegrade puncture for the common femoral artery. You negotiate a catheter and a wire to the level of the popliteal artery, which you can see here. And there are many branches which supply the different compartments of the knee, and they can be quite variable. I know Dr. Bagler can describe the different incidences of the different variations quite well. And they usually arise off the popliteal artery, and there's one extra branch which can come off the anterior tibial artery called the recurrent genicular artery. As I said earlier, the medial compartment and the anterior compartment are the most commonly affected. So those are the arteries that you're going to be targeting mainly. So this is these images are lifted from Prof. Little's paper. When you get your microcatheter into one of these arteries, Inject Contrast, you see all this haziness here. That's the abnormal synovial enhancement there. And you want to prune that, basically. So you inject these small spheres, they're about 100 to 300 microns, and that is supposed to basically prune the genicular artery and get rid of this haziness, basically, and you get this neat contour of the genicular artery. So that's basically an overview of what happens with genicular artery embolization and the theory behind it. We're here to find out if it works, and so for that I'm going to hand over to Indra, who is going to present the findings of the paper.
So I hope everyone can see the screen. So thanks, Shine, for that summary of osteoarthritis and GAE. So my name's Indra, I'm an F2 at the Royal Berkshire in Reading, and I'm just going to be talking through the paper of the Genesis study, which covers genicular artery embolization. So we'll go through the methods and results, and then a few thoughts I had reading the paper. So the Genesis study is a single center prospective study, and the aim was to evaluate the feasibility and safety of genicular artery embolization for knee osteoarthritis. So the patients included in the study included patients referred to secondary care for management of their osteoarthritis, with the inclusion criteria here to age 45 plus. The osteoarthritis had to be mild to moderate, and that was defined by the Kellgren-Lawrence score, which we'll discuss a bit later. They had to have pain for at least 6 months and had trialed conservative management like lifestyle and analgesia and failed that management. And so these patients underwent embolization of those hyperemic vessels, along with the ice pack technique, which we'll again touch upon a bit later. In terms of the outcome measures of the study, this included 3 main endpoints. So primarily the symptom score, and that included the VAS score and the KOOS score, again, which we'll go through in detail in just a second. And that also included the MCID calculation. Radiologically, an MRI was performed at baseline and at 12 months. And the WORMS criteria, which is a set of imaging criteria looking at the MRI images, was used as well. And finally, patient satisfaction measures were also used in this study. So as Shine mentioned, in terms of what we're looking for the images, these hyperemic areas were embolized and the blood supply was stopped to those areas. And so picture A shows the pre and B shows the post-embolization images. In terms of the results of the study, so out of the 38 patients who were selected, 32 underwent successful embolization. Within those patients, there was an improvement in the VAS scores. And so that is a score of pain intensity. So essentially, patients score out of 100 how bad their pain is. And the graph on the top right, or the box plot, shows the progression of these scores at 6 weeks, 3 months, and at a year. In terms of the KU scores, this is a scale covering multiple areas, so daily living and other subdomains within osteoarthritis. I've only shown the daily living scores here, but the other scores were also reported in the paper. And all subscores showed a statistically significant improvement at 6 weeks and 3 months. At 12 months, the daily living score was not statistically significant, but the others had a p-value of less than 0.05. So I thought I'd briefly touch on MCID and explain the importance of that. So the MCID is the minimum clinically important difference. So a lot of these numerical scores, an improvement might not be that noticeable for a patient. So for a given score, the MCID is defined as the minimum change that a patient would need to actually notice a difference. And as the paper mentioned, it's not that well defined for osteoarthritis, and a threshold of 10 was used in this paper. When I was reading some other papers, I think the threshold used varies a little bit, and some other papers that evaluated total knee replacements use a little bit of a higher MCID. And so for this paper itself, the table shows the percentage of patients that reach that threshold at 6 weeks, 3 months, and a year. And so these figures are just shown, included for reference. And in terms of radiological and patient outcomes, so the worm score is an assessment of various features of the MRI. And so this, the post-MRI showed statistically significant improvements in the total score. So there were two MSK radiologists who reported the scans. And sometimes with these things, there's a bit of difference in how each observer reviews the scans. And so the inter-observer reliability is a measure that's used to quantify that discrepancy. And here it was good to excellent, showing that there was good agreement between the two radiologists. And then we've also got patient reported outcome measures, and generally these were favorable. The scales that were used were slightly varied, but it was reported as the percentage giving a positive response, and this was 75%. In terms of complications of the procedure, so the main one was skin discoloration, and that's from non-target embolization. So the embolization particles not going to the skin rather than the hyperemic areas. And that's actually a lower percentage compared to some previous articles attributed to the ice pack technique, where an ice pack was placed on the patient for about 15 minutes. And the theory being that that causes vasoconstriction and reduces the risk of non-target embolization. And one patient also had a groin hematoma as a complication of the procedure. So in terms of overall strengths, so I thought overall this was a pretty good study. The aim was very clear. It was to evaluate whether genicular artery embolization is safe and feasible. And those outcome measures were appropriate for that question. In terms of the group size, it was a slightly larger group size at 38 compared to some of the previous articles. And generally speaking, the results were consistent with what's already in previous literature. So a few limitations that I picked up on. So the first thing was a potential selection bias. So the patients who were already referred to secondary care were reviewed for the possibility of entering the study. But lots of patients will have osteoarthritis and not be referred this early on. And potentially there was an issue with the COVID pandemic changing referral patterns. And so there's a possibility that some patients may have been missed out. In terms of the assessment of severity of osteoarthritis, so the Kellgren-Lawrence scale is a radiological measure, whereas clinically we would do it based on symptoms. So there's a bit of a discrepancy there, although Kellgren-Lawrence is a scale that has been used for a very long time. The MRI at 12 months. So the paper says that the radiologists were blinded to the patient characteristics and outcome measures. It doesn't specifically say that they would know that this was a post-GAE scan, and so there was a potential for introduction of bias at that point. And the other thing that I noted was a lack of a control group, although this does raise the question of what the control group should be. So should that be a control group which undergo repeat conservative treatment, because that would probably be what they would undergo in real life, or potentially a sham procedure where they weren't actually embolized, and that would determine the impact of the procedure itself. So thank you for listening, and I'll pause my presentation there and hand back over to Cheyenne.
Okay, great. Thanks for that overview of the paper and discussing some of those limitations that you've mentioned. I think I'll start off asking Mr. Tilley. As we've identified, there's a lot of space in this grade 1 to 3 group. Based on this study and other studies that you've seen, the outcomes of, where would you place GAE as a contender, in the race of treating these patients? Do you think it's well placed, or do you think there's a lot more work that needs to be done?
Cool.
Unmute.
You're on mute, Simon.
Yeah, it's difficult to know at the moment, I think, because we need to see how things pan out over time, and looking at the further follow-ups will be very interesting. I think there are big deficiencies with the scale, with the Kellgren-Lawrence scale. I think some of my happiest knee replacement patients have been ones with a tiny little ulcer, a little full thickness ulcer that hasn't responded to, all the more conservative lines of management, including microfracture, stem cells, cartilage transplantation. And, and you can't even see that on a plain X-ray. At the moment, I've got a patient who I've requested GAE on as a purely palliative case. He's a chap with amyloid, young guy. He can't even open his mouth we're certainly not going to have a spinal. He can't be intubated. Unfortunately, he's going to die in the next couple of years, and he's in agony in his pain. He's purely patellofemoral joint, and I think he'd be on sort of humanitarian grounds, I think he'd be a great case to do. So we're teeing him up at the moment. Having thought about it, it's really interesting looking at the distribution around the synovium. I would be very happy to do it with patellofemoral arthritis. They're a nightmare for me. They often the patients are younger. They don't really respond to any kind of sort of cartilage regeneration procedures. It's essentially a non-weight-bearing joint, and therefore I'd be extremely happy for that. For these ones, the recalcitrant cases of fem arthritis to go for this. I do slightly worry about, especially with the sort of patient demographics of those with, early medial compartment arthritis, that if you render them pain-free, you're heading towards a sort of a Charcot type situation, and some of them are complete nutters, and they will go and they'll go and take part in impact sports and things like that, blissfully unaware of what's going on. And it just worries me that I may see people with more rapidly accelerating degeneration, should they be rendered. I don't want to keep people in pain, but I think if all the pain goes, especially with the sort of that group have got that sort of SIP-SONC distribution as well, you could get caught out with the odd early collapse, which would be devastating. So I think for me, really, I think I'd be most interested in the patellofemoral group. and those who are too sick to operate on.
Okay.
Can I
yeah.
jump in? I think that's all. They're all comments that have certainly been mentioned by our orthopods, and Ed Tatum, who I think was a trainee down in the Wessex region, who's been one of the big referrers to the trial. And I think when I first proposed this concept, that was exactly what the orthopod said. And I think that was really one of the important points about having the 1-year follow-up MR to look for any features of rapid deterioration of OA or any osteonecrosis or SONC or anything like that, because clearly that was a concern. Are we going to cause osteonecrosis? I think it's good that we haven't seen that, and we haven't. If we look at that group, the 1-year follow-up, what we haven't found is a dramatic deterioration in their OA, and you could say, well, why is that? And so there are other sort of animal experiments that have looked at this, and aside from blocking the cytokines that cause the pain, there is this theory that those sort of that inflammatory signaling cascade is also there to do with the propagation of the cartilage destruction. Now, I don't think I could stand up, and say absolutely that's what's going on, but it's interesting, and certainly the next 10 to 20 years, I'm sure, of my career is going to be looking at all this sort of stuff as it plays out. I think patellofemoral is absolutely the holy grail for us in this. But like a lot of the treatments that you've outlined, it's also not that easy with GAE, because that joint takes blood supply from all 6 of the vessels and can be a more challenging procedure. Albeit we have had some pretty good wins with that, because again, early on, that's what we were getting. But we do see some good wins from your sort of garden medial compartment OA as well. So I wouldn't completely rule it out, and I think our job is to certainly provide the data. So if at 2 years, particularly when we do Genesis 2, which is as a controlled study, if the control arm, or rather if the treatment arm, have statistically significant propagation progression of their OA, then clearly we need to relook at that.
You did have 4 patients, didn't you, that had, although they improved symptoms and reduced synovitis, they did have increased osteophyte formation and demineralization, didn't they?
They did, and that may well be from what Simon's saying, but actually those patients had a BMI that was statistically greater than the rest of the population, and we know that BMI itself is a reason for more rapid progression. So, hey, look, I'm not going to stand up and say it is or it isn't. I think we need more data on it. But what I would say is that it's not something that we are seeing as an overt signal.
Yeah, just to miss Dr. Bagler there, I was just wondering how the results compare to your own studies. I think it was alluded to that they're quite similar, but you've also had more than 2-year follow-up, haven't you, for your cases?
Yeah, but I agree with Mark, on a lot of what he said. I think a couple of things are important to consider. One is, outside of our studies, which now we have 2-year follow-up on our patients, but even in Yuji Okano's most recent study of, say, 78 patients, he had 2-year MRI follow-ups with no evidence of degeneration based on worm scores. And I think, as you guys know, with plain film interpretation at 1 month and 12 months, evaluating demineralization and osteophytes with slight changes in angles and technique and patient size, it's just not reliable. I mean, at the end of the day, I'd love to say our MSK radiologists anywhere could reliably look at a plain film and even say the difference between a 2 and a 3 and a 3 and a 4. We had the same inclusion criteria years ago we did our study. At the end of the day, I looked at our MSK radiologists, and as much as I respect them, there's just so much variability. But suffice it to say, the MRI findings he had at 2 years were very impressive. No negative outcomes. In our study as well, we didn't have any evidence of bone infarcts or degeneration, like progressive degeneration. But that being said, I think there's a benefit to looking at them long-term, like Mark did with this year follow-up in terms of MRI imaging. And there's also a benefit to looking at them early, because as you know, you might get a transient ischemic result that may not result in a true infarct. And I'm not saying it won't happen, because in the most recent study, you guys may have known, Sid Patia's group at UCLA just presented their data, And I believe they did have 4 bone infarcts. And so, you know, I actually, that speaks to a couple things. One is we're so early on in the technical variability of the procedure that, you know, whether it's the size of the beads, the endpoints that are performed, you know, the volume, it's even the pressure by which they're injected, the number of arteries that need to be embolized. So it's like looking at knee replacement surgery when you only had one component and you didn't even know where to put it. Like, that's, I hate to say it, it's that early for GAE, but truthfully, having done it for hemarthrosis for 15 years and for OA for more than 5 years, I know it works. And we did a placebo study, as you may know, and you alluded to, Shen, is that our second study was a randomized placebo-controlled study. It's just about to be published in JVIR, but we did a 2-to-1 randomization against sham, and sham was a true angiogram with selective catheterization of the arteries. And everybody in the sham arm did not get better, and 95% of the people in the treatment arm did. And that continued on. And then the crossover group also had similar benefit. So it eliminated some of this subjectivity, which I can sympathize, because Mark is probably, the closer you work with orthopedic surgeons, you're going to get referrals like this who are I can't open my mouth, you know, I can't really assess pain very well. I have a million reasons to have pain. You know, there's just so many things that are there that when you get referrals, which you should, I'm a firm believer only from orthopedic surgery, you get the worst of the worst. And I think that brings me to my last point I'll make, is that with the early stages, I am a believer in this concept of patients having this inflammatory pathway, which is disrupted by embolization, because this is not a novel concept. As you guys know, this is a concept that's been around for more than 15, 20 years. The first drugs that were being developed in this space were being developed 30 plus years ago to combat this inflammatory pathway. So I do believe that these earlier patients are going to do better. From the early data we have comparing later stage patients and earlier stage patients, I'm confident in that case. I'm also confident to say that the likelihood that they'll get a Charcot, which was actually one of our, I'm glad you brought that up, Simon, because that's one concern that myself and one of our orthopedic surgeons here at Anderson Clinic in DC talked about early on. But the reality is they're not getting a full denervation of the knee. You know, really, it's just, if there is a local site where they're getting some decreased pain sensitivity, similar to RF ablation. You know, I think we're just more selective of that area, and there's probably an underlying, that scares me more, I think, for denervation injury than this does, because we're more targeted. But that's how I sort of summarize that. But I agree with you, Simon. Like you said, the data is very early. I think the variability in technique is probably my biggest concern. We could talk about that next as we go through some different points in the paper. But I think those things, as they level out over the next 5 to 10 years, I think then we'll have a viable option for patients.
Yeah, I think technique is interesting, because I mean, I think if you compare your data to mine to Sid's, the trends were the same. You had definitely a greater absolute reduction. And so you could drill into that and say, well, you had more in way of non-target. So maybe you were more aggressive, which meant that you pushed your clinical efficacy up, but then pushed your side effect profile or complication profile up. So there's probably a sweet spot, and that's again based on size of embolic, number of vessels you embolize.
Absolutely.
So I think the interesting thing is that the trends, and it's like with all these things, that was interim. And I was saying earlier before you came on, actually the more data, that Genesis 1 is now finished, and the more data that's accrued, actually the more plateau that curve becomes and shifts. So it's like with all these things, everything's easy in hindsight, but we'll see what the final 2-year data looks like. But actually my research nurses are making positive signals about the feedback.
I think from if you look at these individually, Mark, I would say that we start one by one, from the inclusion criteria. It'll probably be important as studies go on to really include patients who just have palpable synovitis, really nothing related to, maybe KL 1 to 4, because you're excluding 4 because they're probably in a burnt out stage. They would be better suited with knee replacement, just like someone, frankly, who's 65 who has internal derangement and they don't have much palpable pain and synovitis, but they have actual structural instability and pain. So that kind of person is probably nice to eliminate. But one thing I think that will be important is palpable. I think that'll help us focus on who is. the technical aspects, I think that did concern me. I mean, in this paper, the technical success rate would be 84%, and defining technical success also, right? So in our PAE papers, as a comparison, right, it's like one target artery embolized. And I would say that if we know you're on the medial side of the joint and there are 3 possible arteries, at least interrogating all 3 and then embolizing all 3 if they're abnormal, that might be a technical success versus saying, okay, at least we got 1 artery. Because Sid's paper too, the technical success rate also was less than 90%. And if you include on an intent to treat analysis those patients, the mean improvement is actually much lower. And I think, like I said to somebody the other day, if we go from a 68% reduction in pain to a 50 or a 40% reduction in pain, we're gonna have a difficulty proving cost benefit, long-term benefit, et cetera. And I think that intent to treat analysis is probably something it's missing from Sid's presentation. And I think it'll probably hold us back a little bit, because we're an orthopedic surgeon, we'll be like, I'm sure Simon, when's the last time you took somebody to the OR and didn't do the knee replacement? Like, it just doesn't happen, right? I mean, it's true, right? I mean, you always get a replacement.
Well, it's interesting actually, and obviously Simon can answer, but I do think the UK model is very different to the US model actually. I mean, I think, from where I sit, our orthopedic surgeons welcome this technique, because these are those patients that keep coming back to clinic, that they've had a steroid injection and had an arthroscopy, and Simon doesn't want to operate on them, so they're just kind of
we can't.
Is that true? I mean, I don't want to put words in your mouth, but
no, I mean it's very interesting times. We've got a local treatment centre here, so all our low ASA grade patients, the ASA 1s and 2s, the straightforward ones, they're all swept up elsewhere. We're left with the absolute grot here, and so I can't remember when I operated on somebody who was an ASA 2 in this trust. I've now got a 2.5-year waiting list because of COVID, and so I mean, this is fantastic. If this is a potential, I think COVID may well prove to be a very interesting sort of discriminator for launching this, especially for the palliative patients. I use that word, but it's if we can buy them 2 or 3 years, potentially more, it'd be absolutely fantastic. It'd be a complete game changer.
So I think you were alluding to the moment, Mr. Tilley and Prof. Leal was also. I think at the moment, NICE haven't got any recommendations on GAE at all, and I know it's becoming quite a popular procedure in the US. I was just wondering if Dr. Cote, how you went about starting your service, and maybe you can highlight some of the differences between the UK and the US in that way.
Yeah, sure. First of all, you guys just had some fantastic discussion. I would agree with all of you guys. I think a lot of the data is still very limited. If you're operating under a trial, I think you can be potentially a bit more aggressive in treating the patients. But I do not operate under a trial, and I treat patients in the setting of VA, and it's purely for palliative measure. So I treat patients, I seek out patients who are not good surgical candidate, who have seen their surgeon and they said, oh, we can't treat you because your BMI is like close to 50, your cardiac risk is too high, your ASA risk is too high, and they've tried every other methods and they can't get the pain relief they want. So these are the patients I've been treating with actually quite great outcomes. And unlike the way Dr. Bagler and Dr. Little treat, I treat with a Kuno's method, the imipenem and celastatin, because our lab has shown that it is a temporary embolic that is almost completely resorbed in 48 hours. So the idea that it's an embolic that stops, interrupts the pain, the angiogenesis and the pain pathway, I think that could be one reason why this works. And our orthopedic surgeons welcome kind of this type of therapy, especially for people who are not good surgical candidates.
So I think that's what you were trying to allude to there, Mr. Tilley, as well, isn't it? The patients that really aren't surgical candidates might be the avenue for us. And before we came on, Professor Little, you were talking about your recent meeting with NICE. What do you think? How would IRs in the UK start a service if they wanted to? Is it only on a trial basis, or is it how would you go about?
Yeah, so I presented it to the NICE New Procedures Committee, probably getting on for a couple of months ago now, and it's out to public consultation at the moment. So we'll see what they say. I think at this stage it really should be within the confines of a trial or prospective audit or registry. It's a bit like at the beginning of PAE. I think there is technical nuance to it. It's not as straightforward as everyone thinks. I think you've got to have good microcatheter skills. And what we don't want, which is what we didn't want at the beginning of PAE, is people sort of having a go and causing complications and causing collapse and necrosis. So I think there's a learning curve, getting a proxer, getting training, trying to really engage with as many educational things as you can, and that guests and other places are doing lots of education around this. So I think it's good that there's a lot more momentum, but I think we just need to be a bit careful about just having a go. I think the way in which Nigel Hacking helped facilitate PAE was fantastic, and if I can do my small bit in the UK to do the same for GAE, then that would be what I'd like to try and do. And with a sort of a UK wide registry where we have centres that are have a proven track record with microcatheter, and whether they do PAE, they would have some training and then enter into a prospective registry or something along the lines of rope, I guess, would be the kind of thing that I've been talking with BSIR and discussions with NICE, etc. So that would be great, alongside obviously the RCT that I'm running for Genesis 2. But I think that's where we are at the moment.
Yeah,
would you agree with that, Sunny, in terms of the US as well? What's going on in the US? Is it very different, isn't it, in terms of how you guys can set up?
Sorry, Mark, I was muted. In the US, the way we're set up is it'll be a long time until it's either, I would say, reimbursed. That's probably the biggest challenge, right? By insurance companies at a reliable rate. Two, from a guidance standpoint, we are 5 years away from with probably another 5 clinical trials, which is another thing, like you said, I would do it in the context of a clinical trial just because it collects data. And if you're not, then do it in a setting of a registry, because otherwise it doesn't contribute. Like I can tell you, when I saw Sid's presentation with these cases of osteonecrosis and then a couple skin ulcers, to me, getting transient cutaneous ischemia is nothing. We get it from all kinds of things. I think that's not an issue. It's like saying you're going to get inflammation in the periprostatic tissues after doing a PA, but it doesn't mean anything, right? So it doesn't prove anything negative to the patient. But when you have these negative outcomes, and those are even in the setting of a trial, but what happens is it's going to immediately arrest a procedure like this and put it under a hot button, where if I was an orthopedic surgeon, I would say, listen, if your incidence of, osteonecrosis is 1 out of 100, I'm not sending a patient for this, because why? I mean, so unless they were totally palliative end stage, like we described, like Simon described those patients, ASA 3, 4, you're like, okay, fine, that's okay, but I wouldn't. And so we have to be very careful with that. So we hear there are probably, I'd say 10 to 12 ongoing studies right now in the US. They range from small to, 40, 50 patients, nothing in terms of a larger scale registry. We have a registry platform we're about to launch soon, but I think, Mark, to your point, it's going to be a long ways away. That vision of it, I think, coming to like technical decisions of, what size bead, et cetera. Like for us personally, we weighed in on 100 micron. Like we started with 75, and then we had some issue 75. We weighed in 100. We went to 1 to 3s, ended up not giving us the pain relief we wanted. So we went back to 100. And so on a day-by-day basis, we do it. Do we accept the fact that we're going to get some skin non-target? Sure. But our endpoints are very early. Like we don't take anybody to even close to stasis. So I think it's that trade-off, and those are the things we're learning over 5-6 years. But as we learn those things, that'll be where we go. Now, real quick on what Yulin's saying is that antibiotic poses a specific challenge here in the US because there's no real support for that, right? Because at the end of the day, money pays for everything. And Merck, who manufactures Primaxin, which is an antibiotic, even if they did pay for a clinical trial, sells that antibiotic for $20. And so they're not going to come around and support a clinical study for a device that they make $1 on. And so at the end of the day, we're going to hit a roadblock in that area too. So just things to consider.
I totally agree with Sunny in that. But yeah, if you are going to do it off trial, definitely make sure they know that total knee replacement is a gold standard at this point. I emphasize it to all my patients, and I only take patients who are really not surgical candidates.
Yeah, that's a great approach.
Definitely gotta document all of that and really explain to them that this has not been completely proven yet.
So, Yulin, a bit off topic there. I know there's some junior consultants and some senior regs that are going to be tuning into this at some point. It's typically described as a procedure that you do on the ipsilateral common femoral arteries where your access is, but I follow you on Twitter, so I've seen that you've done a case radially, at least one anyway. What equipment do you use, and do you find it any technically challenging in any way to access some of the arteries through that radial approach, and what patient selection do you advise?
I actually think I learned a lot from that case, and this is a patient that I chose to go radially because he had really large penises and really high bifurcation. So just going through groin axis was going to be a very high risk. Discussed with him the risk of stroke, decided to go radial. I did use kind of the longest true select catheter. I do think an ideal patient for transradial access does need to be shorter. So like I would say 5'8" and below is something you should consider for sure.
Have you done that yet, Prof. Little, radial one?
No. But I think, hey, look, IR is all about pushing frontiers. It's not something that we would do off the bat. I think it would be absolutely very specific patient selection. But hey, why not? If it's the right case, it's a great trick to have up your sleeve.
I think going back to the paper a little bit, Indra alluded to some of the limitations, and obviously it's basically, you've got bias there with some of the interpretation of the MRI, and it needs to be a blinded study against the sham. I know Sandy Bagler is already about to publish something with a sham, and I guess, is that what Genesis 2 is going to be, randomized control trial? So it's a sham RCT. And so I don't know if you can talk a bit about your upcoming publication in any way, Dr. Bagler.
Yeah, so I'm happy to. So it was a 2-to-1 randomization of sham versus GAE. Like I mentioned earlier, in this study, we actually used 100 to 300 micron resorbable microspheres. We, like I mentioned, all the patients in the sham arm ended up not seeing a clinically significant improvement at 1 month. We gave them four weeks for improvement, after which time they were allowed to cross over. The pain improvement on average, let's say on a VAS scale, was roughly, I remember at the time I had like 68, 70% in terms of improvement. We had one person who failed early and one person who failed late. And our challenge in that study of the differences in who does better or worse really tied into BMI. I mean, our average BMI in the study is like 35. So it's crazy. You compare this to say Okino's study where the BMI was 26 or 25.1 or something. So that was one of the challenges. I think for us, it puts to rest the argument of, does GAE have a placebo effect? And is that placebo effect real? In terms of, is it significant? And so what's nice is the paper will have, for future studies, a placebo effect number for what a sham procedure is. So we'll know that if you undergo a sham GAE, this is what your placebo effect should be. That'll help to obviously have Mark's number as well.
What
Not just
outcome measures did you use?
Yeah, absolutely. So we used a 100-point VAS score, and then we used the WOMAC scoring system, and then we just fractionated it based on the 3 individual scales: pain, disability, stiffness, and then a global WOMAC. So it's based, yeah.
Carry on. I was just going to say, how do you go on? I know that if you go through the various treatment papers on treatment of osteoarthritis, there are these same scales which keep coming up. How do you go about deciding which ones you want to include in your study? And Prof. Little, have you used your ones for any specific reason? So you've got VAS.
Yeah. So one of our orthopedic collaborators is the Anderson Clinic here. You know, Jerry Yang and that group, Bill Hamilton. They were basically the early developers of knee arthroplasty and the implants. And so they're investigators in our study. We went to them and said, what would you use? And the truth is, they're like, there's a little bit of variability from one to the other. And they were like, this is what we've used forever, just tried and tested. We have multiple studies which demonstrate what the MCID is with respect to these scales. That's what I would use. And so I don't think it really will matter much, because KOOS, for example, that Mark's using, they have similar parallels. The challenges
you could derive it from the WOMAC from KOOS. So I could represent my data using WOMAC.
Exactly. And challenges with the scale have to do more with the fact that many of these patients have bilateral knee pain, right? So you treat one knee in this clinical study and they're doing great, but they still have difficulty walking upstairs, which is a significant component of their function because their other knee hurts. So unfortunately, there's a lot about these scales that can limit the ability to assess a patient unless you're only taking patients in your study that have unilateral knee pain, which is not the case, because as you know, most people have medial compartment knee pain if you take all comers. And it's going to be bilateral. So I think those are the limitations, but that's how we decided.
Okay. So any one of the major accredited ones will do basically, and they're translatable. Did you try to use MRI at the worms outcome at all?
We do. We use MRI and then we use a synovitis score. So the synovitis scoring system, I think, part of worms, which is based on, I think it's a 0 to 3 scale based on degree of synovitis. It's interesting. So we just wrote up a paper on this for MRI classification of synovitis before and after GA in like 40 or 50 patients. And the problem with worms is it's subjective. What does a radiologist say synovitis scores from 0 to 3, mild, moderate, severe? So we did measuring of synovial thickening and total synovial joints, the capsular distension at its maximal space. Because no matter what, if you're looking at a T1 post-contrast, if you're looking at a T2, everybody can get maximal thickness. Everyone can look at synovial wall thickness and get a good assessment. And it's an objective number. Because my problem is with all these other scales, there's no number.
I think the reason I ask is because I know, Prof. Little, it's again some of your talks before, you've tried to use functional MRI as a more objective measure of pain, or is it?
So I mean, that's another part of my lab. We've got a neuropsychology lab which is looking at pain at the University of Reading, and I think that's interesting because pain is multifactorial and clearly a lot more complex than just marking a scale of 10 on one day, having a procedure, and then it becomes a 2 on another day. So we are in the throes of looking at the data on that to publish correlations between the neuropsychology experiments and the failure for GAE. And I think, as I'm sure Simon will attest to, 20% of patients have a poor outcome as a result of knee replacement, and then it's trying to establish, well, why is that? Was it a bad operation, bad patient choice? Was it the neuro-knee axis, which we sort of thinking about? And that's interesting because actually with that neuropsychology stuff, you do predict, and we're doing it the same with fibroids as well. So looking at which patients are going to fail a day case fibroid pathway, and you can kind of predict based on things such as their anxiety scores or their pre-catastrophizing scores, and the way in which they translate from acute pain to chronic pain states, those patients that are going to do badly from an intervention. And so you could look at that in 2 ways. You could say, oh, if you've got very high scores, because we're not going to go anywhere near these patients because they're going to have a bad outcome. But actually the clever psychologists in the lab are now saying, well, actually what you can do is you can do neuro-linguistic programming or sort of cognitive behavioral therapy to augment the scores. And actually, if you did that preconditioning up front, they might get a better outcome from the intervention, whether that's knee replacement surgery, GAE, or other. So there's a huge interplay between the facets of chronic pain with knee OA, which we're trying to sort of link into GAE, but obviously you could link it into any of the interventions. It's just predicting those patients that traditionally aren't going to do as well.
That sounds fascinating. I don't know if that's something you'd be interested in exploring, or you're already aware of, Mr. Tilley, in sort of surgical outcome measures, or just choosing.
Yeah, absolutely. Yeah, no, I wish I
thing you just say, yeah, need some CBT. That one definitely. Well,
I wish I could pick the winners and more importantly the losers. So yeah.
I think, relating back to this inflammatory cascade, which is, well documented, probably quite difficult for some of our listeners to fully get their heads around, because we're all registrars and junior doctors. But I was just wondering, Mr. Tilley, if you're aware of any sort of medical treatments which are effective or are looking to be effective at blocking this neoangiogenic pathway, or any biological treatments or anything like that.
Well, no, I mean, you briefly touched on it at the very beginning with the microfragmented fat. The pathways are allegedly not dissimilar, but no, there's nothing else currently that I'm aware of. I mean, everyone claims with whatever they're largely injecting into knees or around knees that it does disrupt this pathway. It is very interesting. At the beginning of COVID, when we had no idea about the role of steroids, we were told to stop all hip and knee injections, but for palliative reasons, we did continue with a few without the support of the majority. And actually, it's quite interesting. A lot of us who continued, we actually went down to very, very small doses of steroid. And actually, looking back now over the last year, my outcomes with very low dose steroid combined with hyaluronic acid have actually been better than my standard dose. So my practice has changed, and it's whether how that is linked into the pathway, I don't know, but it certainly caused a change in practice.
So sort of a clear open road, but maybe not for GAE.
Yeah, I mean, there's so much that we really don't get, but I think it's a brilliant topic, and we haven't even got on to things like the inflammatory arthropathies and the role for that. Clearly wanting to maintain a conservative line of management rather than joint replacement. Obviously, disease-modifying drugs and things like that has changed, the environment hugely in that respect. But I still think that GAE could be very helpful with that. And also other things, maybe the crystalline arthropathies as well. I think the potential is huge.
I've just noticed that we are kind of running out of time here. It's been a fascinating discussion. I think maybe I'll leave. I don't want to put you on the spot, Prof. Little, but seeing as it was your paper, do you have any closing remarks or anything that you'd like to improve from your paper or study?
Well, it's like all these things, you could always do things better, but I mean, I'm it's like all these things. I've got a fantastic team around me, so I just really want to say thank you to everyone that was involved in it and is continuing to be involved, because anyone that's done research will realise it's hard work to get to that stage, and it wasn't always plain sailing. So that, as the springboard to Genesis 2, has been good, and thanks goes to the University of Reading, the Royal Berks Hospital, and also the NIHR, who supported it, as well as Merit, who funded Genesis 1. So big team effort, and I think that people like Sunny and Akunu and Yalan, who's doing some great work as well, treating the guys on the ground, it's hopefully all going in the right direction. And really, my closing remark would be, we need data. So if I can help in any small way others to do cases or get prospective data out, then that's what we need to do as a community, because that's that's the only way to evoke clinical change is through evidence-based medicine. That's the bottom line.
Brilliant. That's great. I wish we had more time, but we don't. So thank you very much to Indra for presenting the paper. And I want to special thanks for Yilin and Sandeep Bagler, who have joined in from the States. It's mid-afternoon there, so it's got to be tough. And thanks Simon Tilley again for giving us an orthopedic perspective. If you have any feedback, that'd be much appreciated. And please tune in next month for our next session, which is going to be on IVUS. Okay, thanks very much, Brian.
Thank you very much indeed.
Great job.
Thank you.
Thank you. Good night.